Hi everyone, my name is Nikki McFarlane and I'm going to be presenting to you today on gender and human rights, specifically looking through the lens of Indigenous women and their babies. And I'll be arguing that the failure to improve Indigenous health is in large part due to a lack of culturally safe care. I'd like to start by respectfully cautioning Aboriginal and Torres Strait Islander viewers that the following presentation may contain images of deceased persons. First, I'll look at human rights treaties that protect women and babies. Then I'll examine the Close the Gap goals in relation to pregnancy and childbirth and the progress that's been made in maternal and infant health. Next, I'll examine racism and bias in maternity care and how that impacts physical, social and emotional well-being. And finally, I'll provide examples of culturally safe models that are effective and identify what is needed for culturally safe care. The United Nations recognises that states should afford women and children special rights, particularly during pregnancy and childbirth. Article 12 of the CEDAW highlights that states should ensure equal access to healthcare and access across genders. Women should have appropriate services during pregnancy, confinement and the postnatal period. Article 24 of the Convention on the Rights of the Child identifies state parties as having an obligation to diminish infant and child mortality, ensure the provision of necessary medical assistance and healthcare to all children with an emphasis on the development of primary healthcare, and to ensure appropriate prenatal and postnatal healthcare for mothers. Article 5 of the ICERD states that every person has the right to public health and medical care. And the UNDRIP protects the rights of Indigenous people to practice their spiritual traditions, to be actively involved in health programs that affect them, and where possible, to administer those programs through their own institutions. In recognition of health disparities between Indigenous and non-Indigenous people, Close the Gap was launched in 2008, a strategy from the Council of Australian Governments, the COAG, to eliminate the disparities by 2030. They committed $4.6 billion to programs that focused on 6 key target areas within health, education and employment. One of its goals was to halve the gap in child mortality of children under 5 by 2018 through funding programs that aimed to improve access to antenatal care, offer home visit services and strategies for reducing the incidence of smoking during pregnancy. So how successful has Close the Gap been? Sadly, not very when it comes to maternal and infant health. In terms of premature birth, Indigenous babies are now more likely to be born premature than they have been at any point in the last 9 years, with the gap between Indigenous and non-Indigenous prematurity not changing at all since Close the Gap was launched. While the rates of perinatal death have improved slightly since 2008, and the rates were steadily declining, 2016 and 2017 saw significant increases. Perinatal death is the death of a baby during pregnancy or in the first 28 days of life. The Australian Human Rights Commission, or the AHRC, uses low birth weight as an important measure of the health and well-being of a community because low birth weight infants are at greater risk of dying in their first year, more likely to have episodes of illness through childhood, and more likely to develop chronic diseases in adulthood. We can see that the gap has not improved and low birth weight is now more common than at any time since 2011. Since Close the Gap was published, the risk of Indigenous women dying in pregnancy or childbirth has nearly doubled. The latest report showed that Indigenous women are now 4.6 times more likely than non-Indigenous women to die. The most recent data didn't include the Northern Territory, so the actual risk is likely to be higher. In carrying out a comparison of Indigenous maternal deaths with other countries, I found that Australian Indigenous women are more likely to die in pregnancy or childbirth than women in Egypt, Romania or Iran. Their maternal mortality rate ranks 75th compared to other countries. If we look at the increased risk for Indigenous babies, we find that on all these measures the risk is nearly double, and that the risk for Indigenous women is nearly 5 times that of the non-Indigenous. As you can see, the gap is getting worse rather than closing. So why has Close the Gap failed to address these health disparities? In 2018, the Close the Gap Steering Committee released a 10-year update which was highly critical of the way the strategy had been implemented. In reflecting on their report, it's clear to me that the Australian government failed in several areas. It took 7 years for an implementation plan to be developed, leaving the period from 2008 to 2015 without any clear direction. There was an expectation from many that changes would be seen within 3 to 4 years, despite several evaluations of the strategy identifying that this was a long-term plan. building infrastructure, and eliminating disparity are not something that can be achieved in the short term. Health cuts were made in the Commonwealth budgets, and funds that had been allocated for Indigenous programs were redistributed without consultation with Indigenous people. However, I believe the most significant reason that Close the Gap has failed to achieve its goals is due to the lack of culturally safe care. There was minimal investment in Indigenous-controlled health services and a failure to seek out Indigenous voices when determining what programs to deliver and how to deliver them. There's been minimal investment in cultural safety training or steps to eliminate institutional racism. The Australian Human Rights Commission highlight the importance of addressing racism and in particular institutional racism within the health system. Stereotyping, lack of access to healthcare in rural and remote communities, different treatment of Indigenous people and a lack of culturally safe care all contribute to health disparity. The prolonged and regular exposure to both institutional and interpersonal racism leads to chronic stress. This, together with intergenerational trauma and the ongoing trauma that many Indigenous people face, is associated with poor health. Healthcare research shows that interpersonal racism is so common that when asked, more than 40% of Indigenous people say they have experienced it in the last 4 weeks. Half of the women giving birth in South Australia in one study found that they had experienced racism in their maternity care, and these same women were more likely to give birth to low birth weight babies. When an individual has previously experienced racism within the healthcare system, they're less likely to seek out antenatal care. Institutional racism exists within healthcare, where there is funding and treatment inequity. While slightly more is spent on Indigenous people, $1.38 versus $1 for a non-Indigenous person, it does not account for their far greater health needs when their disease burden is more than double that of non-Indigenous people. It's also evident that there is less spending on primary health programs for Indigenous people, but more hospital admissions, indicating that there is not enough done on preventative health care. Another way that institutional racism exists is the lack of culturally safe models for women to birth. Let's look at this in more depth. The social and emotional well-being of Indigenous people recognises that their connection to land, culture, spirituality, family, and community are important to people and can impact on their well-being. It also recognises that a person's social and emotional well-being is influenced by policies and past events. Despite a midwifery review from 2009 recommending that Indigenous women should be supported in their right to birth on country, most Indigenous women still do not have this opportunity. Those who live in urban settings are more likely to give birth in large city hospitals, where care is predominantly by non-Indigenous people who don't understand the needs or culture of Indigenous women. Those who live in rural or remote settings are typically flown to or evacuated the closest large hospital at 36 weeks of pregnancy, staying in a hostel while they await the arrival of their baby. This not only separates them from their country and traditions, but from their partners, female relatives, and other children, causing psychological distress for many. Their options for returning home are limited as bus services back to their town are infrequent, and they're usually travelling alone with a new baby, leaving them vulnerable. This practice of evacuation is continued despite the lack of any evidence that it improves outcomes for mothers or babies. Indigenous people have experienced trauma either directly or through intergenerational trauma. The ability to give birth in their own country and carry out traditional practices surrounding pregnancy and birth can be emotionally healing for those who've experienced trauma and holds strong spiritual significance. This ability to birth on country and return to their sacred birthing place carries deep meaning. One Wiradjuri woman, Fleur, noted that traditional birthing practices had set herself and her community upon a healing trajectory, a healing journey of rebirthing our songlines. Traditionally, birthing on country means birthing in your own country, using traditions and ancient cultural practices that surround pregnancy, birth, and motherhood. But it can also mean adaptation to a modern birth environment. In a birth centre or hospital setting, it means the provision of a midwife for continuity of care, preferably one who's Indigenous themselves. In a recent open forum, midwife Cherise Buzzacott highlighted how important it can be to have a woman who's also a midwife who's also Indigenous in helping women to feel safe. It means practices that are defined by the woman and her elders, having the people present that the woman chooses and how fathers engage with the baby on first meeting them, a smoking ceremony for the baby, and determining how the placenta will be cared for and where it will be buried, and these differ across language groups. There are a number of effective culturally safe models. The Birthing on Country project, launched by the Australian College of Midwives, is one, but there are many others. They've demonstrated that through culturally safe care, they can reduce the premature birth rate, improve maternal health, save lives, and heal intergenerational trauma. These programs have been successful in both urban as well as rural and remote settings. Primarily, women need to feel culturally safe. They need to know that they will be respected, not be judged, and will not have their children removed from them. The government needs to provide more support for educating Indigenous healthcare workers, ensuring that they are employed at all levels, including senior levels. Indigenous people should be engaged in program development and have the opportunity to deliver services and programs. There needs to be adequate funding and treatment options that are equitable, recognising the increased needs and therefore costs for Indigenous people, together with a far greater focus on primary care. Cultural safety training should be required for all who work with Indigenous people and take steps to eliminate structural and institutional racism. They need to follow through on Close the Gap as a long-term strategy rather than expecting outcomes to improve within one election cycle for political gain. The AHRC highlight that due to a lack of national agreement, poor leadership and inadequate funding, the nation is now in a situation where the Closing the Gap targets will measure nothing but the collective failure of Australian governments to work together and to stay the course. Investment in Birthing in Country and other culturally safe programs would respect the culture and traditions of Indigenous people, improve health outcomes, and honour Australia's commitments to the UN treaties and declarations that it's ratified. I think that Fleur, the Wiradjuri woman that I mentioned earlier, beautifully describes the spiritual significance of Birthing on Country and the essential part it can play in healing from trauma. In Fleur's words, "I believe in the power of birthing as country and birthing in the bush as a catalyst for the empowerment, healing, and rebirthing of our cultural ways of being strong parents, strong guardians of our future, and strong guardians of country. And every connection and every layer of healing brings another piece of place and story as country. We're building back the positive songlines all over our country as the layers of healing in us and the layers of healing in country continue to return and magnify." I've included the references used in this presentation here. Thank you so much for watching. I hope you found it interesting.